Welcome everyone to today's webinar. I'm Laura Lubbers and I'm the Chief Scientific Officer at Citizens United for Research in Epilepsy, or CURE, and I'm delighted to be with you today. Today's webinar is entitled Transforming Data into Seizure Control with Learning Healthcare Systems, and it will discuss the progress and potential impact of the Pediatric Epilepsy Learning Healthcare System to people with epilepsy, their families, and to the entire epilepsy research community. This is our third installment of our 2020 Leaders in Epilepsy Research webinar series, where we highlight some of the critical research that's being done on epilepsy. Today's webinar is being sponsored by our friends at the Band Foundation. CURE's mission is to find a cure for epilepsy by promoting and funding patient-focused research. CURE has been instrumental for over the past 20 years in supporting groundbreaking research from around the world. Before we get started with today's webinar, I'd like to take this opportunity to highlight CURE's new COVID-19 and Epilepsy Resource Hub that can be found on our CURE homepage at www.cureepilepsy.org. This resource contains information on the impacts of the COVID-19 pandemic on the epilepsy community and resources to help families, patients, and caregivers stay safe and healthy. Today's webinar is again focused on learning healthcare systems and will be presented by Dr. Zach Grinspan, who is Associate Professor of Population Health Sciences and Pediatrics and Director of the Pediatric Epilepsy Program at Weill Cornell Medicine in New York City. He's the primary investigator of the Pediatric Epilepsy Learning Healthcare System Project and the Rare Epilepsies in New York City Project. And he currently serves as the chair of the steering committee for the Pediatric Epilepsy Research Consortium. His research includes investigations in comparative effectiveness research, epidemiology, health services research, and the role of computers in medicine. Before Dr. Grinspan begins, I'd like to encourage everyone to ask questions. You may submit your questions anytime during the presentation by typing them into the Q&A tab located at the bottom of your Zoom panel, and then click send. I want to thank those who have already submitted questions in advance of today's webinar. We will do our best to get through as many of them as we can. We do want this webinar to be as interactive and informative as possible. However, to respect everyone's privacy, we ask that you make your questions general and not specific to a loved one's epilepsy. I also want to mention that today's webinar, as well as all previous and future webinars, will be recorded and are available on the CURE website. So with that, I'd like to turn it over to Dr. Grinspan.
Great. Thank you, Dr. Lubbers. It's a real honor to speak to the CURE community. And it's nice to see you, though virtually. We've had some really wonderful conversations about epilepsy and epilepsy research, and I'm glad to continue those conversations today. Hello, everyone in the audience. I'm Dr. Zach Grinspan at Weill Cornell Medicine, and I'll be talking today about the Pediatric Epilepsy Learning Healthcare System. Just first, a thank you to the funders of this work. There's 5 that I want to give a shout out to. Our institution, Weill Cornell Medicine, has provided funding. The Pediatric Epilepsy Research Foundation has provided a significant amount of funding to this effort. The Band Foundation, the Epilepsy Foundation, and the Morris and Alma Shapiro Fund have also made significant contributions, and I'm deeply grateful to all of these funders for making this possible. So let me start by talking at a high level about what a learning healthcare system is. The concept seems so straightforward. We should practice medicine, take notes about what we do, learn from that, and then change. The challenge is that in the current academic environment, that cycle can take 17 years between when you pull in the data, you make your tables and figures, you write your paper, you get it out to the journals, and then somebody hopefully somewhere reads it, it gets incorporated to statements, and then slowly but surely people change their practice if what you have learned is actually important. A learning healthcare system tries to make those cycles of improvement faster. The idea is that You capture data about what you're doing in real time when you're doing it. And you have plans and a bunch of questions in place already, as well as a system to pull that data and analyze it so that you can learn from it, feed it back to all of the providers and the doctors and the nurse practitioners who are taking care of people with epilepsy, and then change. And then what's nice about having this cyclical approach is that you can do it in cycles again and again, and continually move towards the best possible outcomes. The model that we have been really excited about has been a group called Improve Care Now. These are not epilepsy doctors, they're pediatric gastroenterologists, and they take care of children with Crohn's disease and ulcerative colitis. As the story goes, and I apologize, I am sure I am botching the details, but as the story goes, 3 or 4 of the experts in the field, maybe 10, 12 years ago, are sitting around a table. How are your outcomes? How are your outcomes? And no one really knew. So they went back and they found out that about half of the time, kids with ulcerative colitis or Crohn's disease were in remission. So at their first meeting, they say, okay, we think that the biologic ceiling, they say, for our disease is like 64, 65%. They banded together, they started collecting data, they learned from it, they made changes in their practice. Their initial 3 sites are now more than 100 across the country. And actually the Anderson Center out of Cincinnati Children's that runs this has now taught their methods to several other learning healthcare systems. But these are their results. And this is just through 2012. So you can see here on the left, when they start, they're at 50% remission. And then as they track their results, those are these blue dots, they gradually get up to over 75%. And by 2012, they're almost at 80. Since then, they've blown past 80%, and they've done better. So to me, when I saw this data, I got very excited because A, they blew past their own expectations. And then when I talked to the folks that started this, they clearly had the same passion that I've seen in my academic colleagues in the pediatric epilepsy world. So I said, man, we got to do this for our disease. We weren't the only ones that had this idea. There are actually 2 epilepsy learning healthcare systems. I run one of them, the Pediatric Epilepsy Learning Healthcare System. But I do want to give a shout out to our collaborator in this, the Epilepsy Learning Healthcare System that's run out of the Epilepsy Foundation. Brandy Fuhrman and Sue Herman are the leaders of that effort. And then interestingly, we share, there's a gentleman, Jeff Buchalter, who's a giant of the field, who is a leader for both of these efforts. The Epilepsy Learning Healthcare System, they affectionately call it ELLIS, is really quite collaborative and driven largely by advocacy efforts, and brings together people with epilepsy, providers, community service organizations, and researchers. And they have a broad and broadening reach in partnership with the EF offices around the country. They have several epilepsy organization partners, and then they have sites in several states around the country. What I like to say is that we're parallel and aligned. We're on a call with them fairly frequently, and Dr. Buchalter is always looking for ways for us to work together. The Pediatric Epilepsy Learning Healthcare System, just by way of history, grew out of an organization called the Pediatric Epilepsy Research Consortium. Thanks for your patience with this alphabet soup. PERC is dedicated to collegial, collaborative, practice-changing research. And there are more than 50 sites around the country. This map is a majority of them, but we need to update it. And that group has done a lot of really important research. We published an enormous series of children with infantile spasms in 2016. That was a project led by Kelly Knupp. Ann Berg has done really tremendous work looking at early life epilepsies. The thing about PERC is that the research we did was amazing, but it built this social foundation where there were a group of 50 to 100 academic pediatric epilepsy doctors that all learned how to work together on these projects. And that social glue really set the stage for the learning healthcare system. In that it allowed us, we had pre-existing relationships, we trusted each other, we knew how to work together, and this got us going. So the Pediatric Epilepsy Learning Health System, our mission is to reduce seizures and their consequences for children with epilepsy through cycles of health data collection and analysis, dissemination of new evidence, and practice change. And our vision is that all children with epilepsy receive timely and optimal care according to standards that are continuously improved. And so it's inherently dynamic so that we always learn and are always trying to do better. I've had the honor of leading the effort, and I have these amazing collaborators that round out our leadership team: Anu Patel in Columbus, Ann Berg in Chicago, Renee Schellhast in Michigan, and I gave Jeff Buckhalter a shout out already. So this is how it works at a high level. You can imagine that we have all of our sites, and there are I think we are 21 or 22 now. 13 of them have given us data. All of these sites have data in their electronic health record systems. And that data just goes in there as part of routine care. When you register at the front desk, some of your demographic information goes into the computer. When the clinical team sees you in the office, they're taking their notes, and sometimes their notes they're using, they're pressing buttons and it's structured fields. This is what the patient has. And then when a bill is submitted to the insurance companies, there are additional pieces of information that are quite valuable that go along with that. So all that data is just sitting there. And the idea is that we ask all of these sites to collect all that data and send it to us. There's really 3 buckets of data that we're after. The first bucket is what I just described and what we call the structured data: demographics, insurance, visit history, your diagnosis codes, the medications prescribed, any procedures that are done, et cetera. And honestly, of the work that we're planning and the work that we're doing, this is the easiest piece. It's just there. You got to figure out who has it, how to get it out, how to move it, and how to process it. But each one of those steps is quite straightforward. The second bucket is the hardest: the clinical data. There's no clear way in all of our electronic health record systems to know if a child is seizure-free. I might say, Johnny had no seizures since last visit. Someone else might say, Johnny's doing great. Someone else might say, no seizures since last spring. And it's always different. And there's a million ways to say this. So if we could figure out how to document that in some way, that we all had that same information and we could learn from it, then the sky's the limit and we could really do a lot. In order to do that, we have to design a form for people to use, and then we have to get them to use it. The third bucket we know how to do, it's just expensive. I call it the fine phenotype, and that's, which voxel on the MRI is bright, which lead has the spike on the EEG, what's the particular mutation. All that data is there, but it's harder to get out because it's in these specialized areas. And so we're imagining that to get that data is going to require research assistance and large grants to get this data to merge with what we have. We have our sights on 5 domains of research. The first domain is quality, which is to say, we know what we're supposed to be doing, we're not doing it, why, and how can we be better? We also have our sights on comparative effectiveness research, which is to say, we have some disease, some people use drug X, some people use drug Y, which one is better and by how much? And then we're also interested in 3 other domains: surveillance and epidemiology, which is the incidence, prevalence, comorbidities, and mortality of disease; health services research, which is the organization, financing, and delivery of healthcare; and then clinical care of populations. How do we know if people with epilepsy as a group are doing well? How do we measure that and move the needle? And then what makes this a learning healthcare system is that all the data that we collect and analyze, we feed back to the sites so that we're always learning. A brief word about governance, just to kind of give everyone a sense of what we do and how we are structured. We have a leadership committee that I lead and the other folks that I mentioned before on there. And then we have 3 learning collaboratives. Each of these groups meets by phone once a month, and I join all the calls. And those, I got to tell you, those are some of my favorite calls every month because it's always a mix. You get clinical site leads that are often MDs and NPs from around the country. We have parents and advocacy group leaders that join these calls. And then we also have representatives from professional societies. And those roll out. The leadership committee meets once a month. And then we have an advisory group of experts in informatics, comparative effectiveness, and then in epilepsy specific research. We're off to the races. Just to give you a sense of where we are, there's 20 centers, and here I'm giving them all a shout out. I won't go through them all. And 13 of these sites have provided that first bucket of data, the standardized, structured electronic health record data. To give you a sense of the scope, it's 500,000 people in this data set, 33 million medication events, 8 million outpatient visits, 300,000 inpatient admissions, and 2 million emergency department visits. When we think about the research studies that we want to do, we realize that we have 60,000 neonatal visits, 100,000 infant visits, 200,000 early childhood visits, 200,000 school-age visits, and 130 visits in adolescents. So, you know, the scope is really, you know, gives us pause and gives us a sense of the potential for this network to really make a difference and to really help us understand how to do the best possible work. I wanted to give the audience an example of something that we've started working on. Many of us are quite passionate about infantile spasms, and so we started there. I mentioned PERC. One of our big early studies was that we put together a national infantile spasms cohort, NISC, to look at what medications people were using in their outcomes. One of the things that we noted was that at our academic centers, 1 in 7 children was not receiving what we considered to be first-line care. As you all know, there are really only 3 medications that have good evidence for use as first-line therapy for infantile spasms: ACTH, vigabatrin, and oral steroids. And if the oral steroids are going to be given, you have to use a good dose, 4 to 8 milligrams per kilogram per day for those first few weeks. So when we saw that 1 in 7 were not getting one of those therapies, that was something that we needed to call attention to. And many of the names of folks who wrote this paper have been giving talks about infantile spasms and encouraging people to try to use those one of those first line drugs for several years now. So here's how we studied this. We said, okay, each of the 12 sites, go ahead and go to your electronic health record and like send us everything. Like don't be shy, send us these huge files. So we get these like 100 megabyte files, a few are in the gigabyte range. We use secure transfer and they come to our secure data facility at Weill Cornell in New York City. Then we do something called source to standard mapping. The data that we get, it's always different, and we send all the sites, all the specifications, and no one listens to us. So the data always looks different, and we have to kind of harmonize it and make it all pretty. And then we came up with a way with some reliability to find children with infantile spasms using some of those diagnostic codes. Then what we do is with free software, this is R, which is free software. We create these HTML reports. They're just websites, and we ship them securely to our colleagues, essentially with a bunch of questions. Then our colleagues use those reports to read up into the charts, and we give them a REDCap database. This is an online secure platform for research with protected health information. So they fill out those REDCap surveys, send us that data, which we marry with the other data that we have, and then we're able to make reports. We can say, okay, you had 20 kids with infantile spasms and you use the right therapy for 17 of them. But we can do that for all of our centers. And then again, we're trying to learn, so we then return those reports to the sites. So it's really 2 cycles, that initial transfer and processing, and then the site review and validation. So just to give you a sense of what we're sending back to the sites, we have all that electronic health record data. So we might give them a picture, something like this. It's like, well, you know, here's this child and there's a diagnosis in the chart for infantile spasms, you know, maybe at 6 months. And we have all the medication information, and it looks like somebody wrote for ACTH. So is that right? Can you just confirm that? I don't see any of the first line drugs. So what happened? And this is what we found. And it doesn't quite show up as, but I think you get the idea. This is quarterly results from 15 through the end of 17. And these dots represent the rate, or the percentage of children across, this was, I think, 12 centers at the time, the rate that was getting first line therapy. And what you can see is that across those 3 years of data, we were at about 90%, 89.5%. So we felt very mixed about this, because on one hand, it was better, you know, 1 in 10 that we're getting wrong is better than 1 in 7, but we'd sure like to be perfect. So we did a little bit more investigation there. Oh, I went too far. And I won't go through the details of what this particular visualization shows, but we tried to understand where was the variation happening. And what we found out is that a lot of the variation was by site, that whether you got first line therapy didn't matter whether you had, infantile spasms for unknown cause, whether it was from tuberous sclerosis or hypoxic ischemic encephalopathy. It didn't matter your race or ethnicity. The only thing that seemed to determine whether you got first line therapy or not was where you got care. But this is what we wanted. This is what makes a learning healthcare system work. So this is 2017. If your dot is at the top, that means that you're perfect. So there were, let's see, 1, 2, 3, 4, there were 6 centers that were perfect in 2017. And then the rest of us were sort of lagging behind. And so what's lovely about having a nice social network where we all love and trust each other, I was gonna say work with each other, but I said love, which is sort of true. We really do, there's a lot of warmth in the group. When you have that baseline, that social trust, it's very easy to say like, hey, you guys are doing something real good. So can you teach us? What are you doing so we can do it too? And I've been part of so many of those conversations. It's really deeply rewarding. The other thing is that there's some social pressure that we've taken advantage of. One of my favorite moments in this whole effort was that one of my colleagues was on rounds, and one of her residents said, we have a child with infantile spasms. I think I'm going to start topiramate. And she said, it's interesting that you said that, because A, that's not what we're supposed to do, and B, none of our peers are doing that either. So maybe we should use something first line. And that kind of social nudge is quite powerful. So, this is data from 15, 16, 17, which we collected when we first started. We'll do another round of this in the next year or two and see how this is improved. We also have more centers, and as we've grown, more folks are interested to see how they compare with others. Let me talk a little bit about some of our ongoing work. One of the nice things about learning healthcare systems is you really, one of the premises is that parents, advocates, and patients need to be part at every step of the process. And we do that too. So on all of our calls, we have parents and sometimes people with epilepsy. One thing we heard again and again is that, epilepsy is not just about seizures, that epilepsy is also about quality of life. So we said, awesome. What do you mean? What is quality of life? How do you measure that? And the answers are sort of tough. The measures that are out there are long. The QOLC 55 is called 55 because it's got 55 questions. And man, we're busy in clinic. So the idea of asking 55 questions in a 15-minute visit is just not feasible. So we said, okay, look, let's figure out what you mean by quality of life, and then let's see if we can come up with something a little bit faster. So we decided through, I think, about 200 emails and several phone calls that a good quality of life measurement had to be understandable, actionable, trackable. It had to measure something distinct. It had to be meaningful. Ideally, something that was published so that it had been validated. It had to be anchored, meaning that there has to be some reference that you're comparing to. It has to be clear, and it has to be feasible to answer in the context of clinical care. And so through those phone calls, and man, we got this wrong the first couple times, but through multiple iterations, we've come up with our solution, and it's 2 questions. First question says, think about the child's usual routines. How often in the past 2 weeks have seizures significantly changed those routines? Every day, most days, some days, or never? And then there's a paired question. Think about the child's usual routines. How often in the past 2 weeks have seizure medication side effects significantly changed those routines? Believe me that we thought about just about every word. The word usual was originally the word typical, and we didn't like that. The 2 weeks was 1 month for a while, and then people said, I can't remember that far. And then we made it 1 week, and they're like, well, let's make it a little longer. So these were iterated quite a few times subjectively. And then what's amazing is we've now piloted this at about 150 visits. That QOLC 55 that I mentioned is our gold standard. So we measured that at the same visits. And what this graph is meant to show is that when you have more seizures, that's here at the left. So if every day seizures are disrupting your child's routines, then the QOLC score tends to be low. And as that becomes less true, the QOLC score is higher. The other thing we did is we had that question on side effects. And so we looked at a measure called PESQ. This is a standardized score for medication side effects in children, and we see a similar correlation. We are continuing to work on this. I was talking to our statistician this morning. We'll probably have an abstract to AES describing this work in more detail. The other thing that we're working hard on is that we want to make sure that at the point of care, we get that middle bucket of data. So I want, as a learning health system, to know which children are still seizing and which children are seizure free. And I want to know lots of other things as well. If there are any clinicians in the audience, you'll recognize this is Epic, which is one of the main electronic health record vendor systems that are in use at most academic centers across the country. So what we're working with them, they have built a button, PELHS, which anyone with Epic will be able to use when they're seeing a child with epilepsy. And when you click the button, this is a mock-up. It's because it's much smaller. They'll get a bunch of epilepsy-specific questions. So, for example, when was the child's last generalized tonic-clonic seizure? It was 1 to 4 weeks ago. And then it asks, okay, well, recently, what is the frequency of generalized tonic-clonic seizures? And then you have some questions there. And so what's lovely about having these buttons with these standardized questions is that we'll be able to collect it. We'll have the IT folks extract this data directly from the notes, add it to our database, and then we can actually know who's seizing, who's not. And that'll help us learn, figure out what's working, what's not, and pass it on to the clinicians in our group. We've got several other projects we're working on. So the quality of life measure I mentioned. We're also interested in other quality of care measures. So for example, we want to make sure that children who have refractory epilepsy, that continues despite 2 medications, that they're getting seen by epilepsy specialists. And then we're very interested in status epilepticus, and we want to make sure that children who show up in the emergency department with unremitting seizures are given the correct therapy at the right time, at the right dose, and we're developing some measures for that. We have our sites on comparative effectiveness. One of the PERC studies that we published a year or 2 ago was that we found that phenobarbital, we compared phenobarbital and levetiracetam for infantile epilepsy. And in that data set, levetiracetam seemed to be a lot better. But we were using a data set that was not designed for comparative effectiveness. So we really want to answer this question more definitively. So we have a big grant under review trying to figure out, if funded, will help us use the network to answer that question. And then we've started our surveillance and epidemiology work. We're quite interested in mortality in epilepsy, particularly in children with epilepsy. Our idea there is not that we're going to be able to provide population-based estimates, but rather that we'll create a process by which all of the clinicians in our group can systematically review the deaths among the kids with epilepsy that we take care of, so we can try to understand, well, man, is there something we could have done differently? Was there something that we can learn from this case? You know, and there's a deep emotional resonance that often happens at those kinds of conferences when you're facing mortality, particularly in children. And so we think that if we launch this, that this will really motivate people to make change in their practice. So that's the end. I just wanted to reiterate our mission, which is again to reduce seizures and their consequences for children with epilepsy through cycles of health data collection and analysis, dissemination of new evidence, and practice change. I thank you to the funders and to all the amazing people who have helped make this happen, and to all of you out there in the audience. Thank you for listening.
Thank you, Dr. Greenspan. We'll now begin the Q&A session. I know a number of questions have already come in. If you have questions, please do submit them in the Q&A tab located at the bottom of the Zoom panel and click send, and we'll do our best to get through everything that arrives. So we've got a number of questions here. One, which is a big data type of question. From a digital perspective, for gathering your data, what are your biggest needs at this point?
Oh, what a great question. Let me be a little wordy with my response, in that it depends a little bit on which kind of data that we have. For the electronic health record data, a lot of it is we have so many conversations with IT groups around the country, and so the need there is as we are imagining going to scale, is figuring out, you know, how do we, you know, I was going to say McDonald'sify it. That's not quite the right term, but how do we standardize that process? Other groups have done that, and I think we need to get better at that. Right now, it's a lot of phone calls and a lot of specifications. It works. We're getting there, but we could certainly be more efficient. We have a good system to transfer the data. Now that we have the data, I think we're starting to run into some bottlenecks with the processing. We have one analyst who's sort of working through it. I think as we scale up, we'll need more people just kind of processing the data and getting it ready. And then, you know, but we have, I mean, a lot of the technology is free, so we have a good pipeline to get the reports out. And then for the other buckets, the electronic health record system questionnaires are you know, they're going to get deployed over the next few months. Epic is going to release our questions this month. Cerner is not far behind, and someone has already built it out in Athena. So we'll want to expand that to other electronic health record vendors. We really want to be vendor agnostic. And then we'd like to bring more data in, you know, the EEG, the MRI, you know, patient reported outcomes would be amazing. Devices, I mean, you know, there's some people who are walking around collecting data moment to moment with an RNS or a VNS. And so, you know, partnering or working together to figure out how to get that data in. I mean, a lot of these, you need people. So some of it is humanware. I think the technology is relatively straightforward. It's just a matter of all the conversations and figuring out how to get the data out, move it, and link it.
Okay. A lot to happen still, but it's great to see it already underway and with so many plans moving forward. So here's a question that sort of touches on what you were just talking about. With the advancements of implants, watches, and other devices, has this helped you understand more about medication efficacy for patients? Has this increased the whole picture of an epilepsy patient's day and changed the way you view potential individual versus multi-drug prescription regimens?
Yeah, it's a great question. And what it gets at is, you know, in the digitized world, you have people who are creating oceans of data, and, you know, can we do anything with it? So for some individual patients, absolutely. There are some patients that come in and you look at their VNS data, you look at the RNS data, and you can make very targeted changes. The question is, how do we scale that and how do we learn from it? I think that the vision that the question asker that's a weird term. that the individual who asked the question posed is really very compelling. We are not there yet, because I don't think we know how to do this yet at scale. It's a long-term goal of ours.
Okay. So along the same lines, is this aggregated data that is collected, data that can be individualized, or data that can be used to provide a service to doctors and patients for a fee? For example, if RNS data is collected, would somebody need to pay in order to see their own data?
That's interesting. There's so many pieces to that. So I haven't had anyone. I don't have any patients who have RNS, but I do for VNS, and I've never had anyone ask me for a copy of their data. Certainly doable, and I don't have any, and it's coming from you, so I don't see any obstacle to that. For the data that we're collecting, other learning health systems have ingested identified data. So like Improve Care Now that I started with, their database, they know your name, they know your date of birth, they know everything. And so they actually do provide, as the questioner poses, direct services. Here is a patient level report about how your patient is doing. We shied away from that really for privacy reasons. Data breaches can be devastating for so many reasons, and so we opted to use less personalized data. So we don't know anyone's names. We do know dates of birth. We do know zip codes, and we have a study ID, but we don't know where you live. We don't know, your medical record number, and that was intentional. Our idea is that we can send information to each center. The center knows who you are, and when we might say patient ABC had this happen, and then the center will have, we call it a crosswalk, but they'll be able to say ABC is actually John Smith, but they have to do that extra step. So I don't know it's John Smith, I know it's ABC. So we get around it a little bit, and it helps make the data a bit more secure. But we're very much about data sharing. And so we have promised all of our collaborators that they can have their own data essentially with no questions asked. We'll just give it back to you. And we've crunched it and processed it a little bit. So, because we want to promote junior faculty, we want to promote residents and fellows to do research projects. And then for the network, if one investigator says, I have an idea, it works on my own data, can I do it on everyone else's data? Then we have a very straightforward process to allow that to happen too. We really all want to learn together.
Great, it's great. And actually it's a great segue into the next question. You've talked about data sharing. Will data sets be made publicly available?
It's a wonderful question. We have not, I don't think we've thought about that really. The data sets we have qualify as limited PHI. It's a technical term from federal privacy offices, which means that we have dates of birth and zip codes. So we would not be able to release that to the general public. But fully de-identified data, I mean, theoretically we could. I think we'd have to talk and think a bit more about that. What a lot of networks do is they want to make sure that when data goes out that it's being used for a purpose that's aligned with the mission of the organization. And so there's often a process. So we don't have such a process in place right now. But if that became something that was of interest to the community, there's no reason we couldn't start planning.
Okay, great. Here's another sort of process question. How have you had to overcome the barriers of institutions not wanting to share their data with other institutions?
I thought that was going to be a huge problem. It doesn't seem to be a problem. Everyone's so happy to share. It's really nice. I think that we're, as much as I'd like to say I'm a pioneer, I'm not. People have been working on this in other fields for more than a decade. So I think that the ground has really shifted, and we're just in a new world. So, there's an the Pediatric hospital inpatient system has data from like 45 centers, and they highlight non-competing hospitals, but Cornell data is in there, Columbia data is in there, NYU data is in there, and you can walk from one to the next, in an hour. So I think that the culture, particularly in pediatric hospitals, is very mission driven, and that these issues of competition and you can't have my data has just not been an issue. There's some centers that have stricter privacy requirements than others, but it's always it's kind of a bunch of phone calls, and especially in the Zoom era, they see your face, they see that you're mission driven and you want to do the right thing, and people are really more than happy to help out.
That's wonderful. That's great news. So here's a question about a specific area of epilepsy. What are you doing to monitor and measure the impact of diet on seizure control?
Great question. So there's no, the structured data that we have does not include, it's not easy rather to figure out who is on an epilepsy related diet and who isn't. So I showed you that one question about the seizure frequency, but we built in some questions also about diet. It's pretty epilepsy specific. So it's ketogenic diet, modified Atkins, low glycemic index, or other. And so that'll give us some high level information about who's getting the diet, does it work, things like that. More detailed information about specific foods and specific exposures would need a whole different level of data collection.
Okay, but it certainly sounds like something that the system could evolve to.
Absolutely.
Okay, great. Here's a question about a different data resource. Are you familiar with the Observational Health Data Sciences and Informatics, OHDSI?
Yes.
Drug use.
Yeah, so let me nerd out for a bit. One of the major questions that we've had is, what do the tables look like in the database? And a lot of people have spent careers thinking about that for health data. There are two major models of how you do that. One is called OMOP, and I think I'm going to mess up the OHD. I'm feeling guilty because I can't remember exactly what it was, but I think the organization, Dr. Lovers, that you just mentioned, uses the OMOP standard, and then there's another standard that PCORI, the Patient-Centered Outcomes Research Institute, has advocated called PCORNet. PCORnet common data model. I think our data looks a little bit more like PCORnet. With the OMOP, there's a lot of linkages you have to do. And like when you're looking at the files, it's a little harder to kind of figure out what stuff is. But we ended up kind of doing it a little bit idiosyncratically. So currently our data model is our own, which could be sort of seen as a simplified version of OMOP and PCORnet. What we told our sites is that, look, if you have the data in PCORnet or if you have the data in OMOP, just send that. Like, don't like reinvent the wheel. But no one's taken us up on the offer. So it seems like operationally, a lot of the sites are finding it easier just to kind of make a custom extract for us and just sending us what we want, which we've been fine with.
Great. Sounds like a very collaborative approach. So here's another question. Would it be beneficial for a healthcare provider to have the PELHS questions answered before the visit versus during the visit?
What a good question. I love that. Yeah, so yes and no. We really want curated data where a clinician's eyes have been on it. So the workflow that the questioner is proposing is a good one, which is that the parents or the young adult or whatever it is enters the data in prior to the visit, and then the clinician and the family review it together, and that would be lovely and fine. That would be totally okay. We've had the linked idea there is that we've had a lot of really nice conversations with Rob Moss, who runs Seizure Tracker, and he's very excited about this idea. So he's been working to link his application with Epic, which is one of the electronic health record vendors. And we've been talking like, well, if you get that workflow there, can the Seizure Tracker data like populate the learning healthcare system data? We're agnostic. If the data gets in there and the clinician vouches for it, then we're good.
Okay. So I want to talk more about the role of the patients and how they interact. So first, are patients and their families aware that you are collecting these data, and how do they feel about participating?
It's a good question. Let me answer that in two ways. So one is we've been very deliberate from the beginning in making sure that we're in communication with advocacy groups and that we have parents and people with epilepsy involved at the highest levels. And so all of the pod calls, typically we'll have a parent, and then sometimes there's a few people with epilepsy that will join the calls also. So there are representatives. What is not true, though, is that people who, if you bring your child to one of the centers that are involved, you wouldn't know that the information from that visit is being brought into the learning healthcare system. We don't do consent, and the reason is that we argued successfully to our institutional review boards that the labor required to get the consent was too much work for this kind of data, and that's the way that electronic health record data is used for research in this country tends to support that. Institutional review boards have these exemptions where you can get an exemption from the federal regulations from HIPAA, and we applied for that and got it. So what that allows us to do is we're allowed to look at the data without 100,000 people's explicit permission to do so. One of the things that makes us comfortable with is that we feel like the good we're going to learn far outweighs the risk to loss of privacy. We've been quite intentional, as I said, about making sure that the data that we have doesn't have a lot of personal information, no names, no addresses. We have dates of birth, but that's, lots of people share same dates of birth. And then, when we've spoken to advocacy groups, most people say like, most people are in agreement with this philosophy that the labor required, it's so much work to get those consents, and we'd spend all of our effort doing it, and they would rather us do the learning rather than the consent. So we're consistent. We got all the approvals. We have data use agreements. We have all the legal and ethical infrastructure. But it's true that you wouldn't know that your data was going to be in there necessarily.
Okay, that's helpful. So you have talked about the role in patients in designing the system to some degree. How have you involved patients in doing this, in the process and the governance? And you've already touched on that a little bit, and wondering if you can comment on whether there are differences between the pediatric epilepsy learning healthcare system and the other system that you mentioned.
Yeah, I think both systems are quite deliberate about it, and both have made a big effort. The ELIS, the Epilepsy Learning Healthcare System, is really run out of the Epilepsy Foundation, which at its heart is an advocacy organization. So I think, the DNA there, I think, is much more about patients' perspectives. We were aware of that. And we wanted to make sure that we were listening, and that voice was there, which is why we bring everyone on the calls. But I can give you some very specific examples. When we put our forms together, we wanted to have a scale, like how often are you having seizures, right? So the original scale, the most you could say was multiple per day. So we're like, okay, that's the most you can have, multiple per day. And a couple of parents were like, my kid has more than that. What do you mean? Multiple per day, that's it. And they're like, yeah, my kids I can't even count because there's so many. So we said, oh, okay, we missed something important. So now the highest level is too many to count. It was originally innumerable, and then one of our researchers were like, that's a weird word, and what does it mean? So we changed from innumerable to too many to count. It's a little bit easier to understand. And then our whole quality of life line of research was very much inspired by parents, where they said, this is important, you have to measure this. And our pushback was like, I don't know what to measure. And our solution to that was like, well, let's just come up with some questions that we can agree on. And then we did.
Okay, great. Lots of learning, lots of iterative learning in this process.
Absolutely.
So you mentioned the example of the ulcerative colitis. Did those researchers identify factors about that experience, the GI experience, that allowed for the increase in remission? And how are you applying that thinking to what you're doing?
It's a good question. I've had several conversations with leaders in that group, and the things that have resonated the most deeply were, number one, to focus on outcomes. And so part of the reason that we worked so hard with the electronic health record vendors is that the most important outcome is seizure control. And you can't measure that with normal electronic health record data. Right now, if you want to figure that out, someone has to open the chart, and that takes forever. So we, from the beginning, made that a priority. We did this whole prioritization process. What are the outcomes that people care about? Seizure control was clearly the number one. And then we realized that the only way to measure that was to get it into the electronic health record. We also learned from them how to work with the vendors, with Epic, Cerner, Athena, et cetera. They had good relationships, and we learned what works, what doesn't work, how to sort of finesse those relationships. And the idea of the pods, Peter Margolis, that's the guy I talked to. So he's sort of one of the leaders. I was at a conference with Peter Margolis in DC. It's gotta be 3 or 4 years ago. And at that time, I'm like, oh, I'll just sort of call like each center once a week and kind of, he's like, Zach, that's too many calls. You can't do that. And so we were just sitting around a table. I'm like, well, maybe we could do like learning collaboratives or pods. And it was just like a what if. And he kind of nodded his head, and then we launched it. So these are some examples. of how we've learned from them. We also have, we have done some things differently than them. For example, they take, as I said, all of the protected health information. They have a very robust but somewhat rigid database system that has worked well for them for more than a decade, but we wanted to be a little bit more flexible. And so the system that I described was really a custom decision by our network to allow us to answer lots of different questions. What else? I mean, those are some examples. I think, we learn a lot from those other networks, and we have been in communication with them.
That's great. It's great to have a network to help support this and inform this. So I think we've time for 2 more questions. One is there the possibility for international collaboration? Could it be even better with hundreds or thousands in the wider group?
I love that. Whoever wrote that question, we are like mind meld. We've had some conversations. Weill Cornell has an academic collaboration with a medical school in Qatar in Doha, and the leader of the epilepsy program, they are actually trained in Columbus, Ohio, where Anu Patel is. So Khalid Zamel is a great guy, and so they may come on board at some point. I trained with this wonderful guy who's now practices in Beirut in Lebanon, and they have Epic. So if we get it into Epic, they'll be able to get it. I've been trying to pitch Ingrid Scheffer on this, who's in Australia. I learned Helen Cross, who's in the UK. She uses Epic, so so it's potentially. So I think the potential is there. What's nice about working with the vendors is that if you build it into the vendor system, then all of their customers, and it's an international group, can then use your form. And then if you get a collaborator, then the data's already there. You just got to pull it out.
Great, great. Well, that was that answer was very much appreciated by the person who asked the question. Actually, maybe we can fit in. Well, we are running low on time, so I do want to ask somebody as a final question: how do I encourage my neurologist to participate in the pediatric epilepsy learning healthcare system?
Oh, I love that. I think just tell them to email me. I don't know what else to say. We are, we have some funding, and we were able for our 20 sites to provide some seed funding. That money has run out, but some sites are willing to join with internal resources. And so we've actually had some interest there. And then the learning, the Improved Care Now, they have a fee for service model. So every site that's in Improved Care Now pays $20,000 into the system every year. We haven't done that. So at present, if there are sites that are enthusiastic, they can just find me and I can have a conversation with them. The other thing is that 54 of the U.S. pediatric epilepsy centers are part of PERC. And I am pitching and giving updates on this through all of our PERC calls. We just had our annual meeting, virtually, unfortunately, last week, and we have calls every other month. So finding out if your center is part of PERC, finding out who the PERC representative is, and then having that person reach out to me could also be effective.
Great, great. Thank you so much. Thank you so much for sharing information on the learning healthcare system and how it's being used to help provide better care for people with epilepsy and their families. I also want to thank the Band Foundation for sponsoring today's webinar and our entire webinar series. And I'd like to thank the audience for the terrific questions that came in. If you have any other questions, please do email them in and we will do our best to get those addressed. If you have any additional questions about CURE's research programs, please do, or future webinars, please do visit our website at www.cureepilepsy.org. Also, please stay tuned for an announcement for our summer webinars that will be coming out in the near future. So with that, thank you and please be safe.
Thank you.